You know, we use scoliosis, right? But scoliosis just really refers to the curve in the, again, like the frontal plane. Most adults, when they have a spine deformity, they have a problem in what we call the sagittal plane, or like the sideways plane. That is really what tends to be most limiting. So when someone's back is forcing them to come forward, the amount of like strength it takes to keep your body upright is really exhausting and can cause a lot of pain. So I actually think really like the best word to use when talking about like adult scoliosis is really like adult deformity, because it involves scoliosis, but it's a three-dimensional thing. So it a lot of times also involves people coming forward as well. In thinking about adult deformity, one reason that I think it's such a fascinating condition is because it creates this like catch-22 scenario for a lot of people where it really doesn't become a problem until your muscles become too weak to overcome it. So a lot of times patients in their 50s, they can have a very curved spine. They may not have any problems from it because their compensation, their ability to stand upright by changing their pelvis or changing other parts of their spine, is still very strong. And then as they get weaker and older, that ability to make up for it starts to go downhill, okay? But then they're in a really tough situation because their body is weaker now. The kind of surgeries that we have now are pretty involved, right? To reconstruct somebody's spine, whether you do it minimally invasively or openly, it's still a big deal to undergo that surgery. Like, you're still reconstructing somebody's spine. These patients are faced with this decision where they either like can continue to live how they're living, or they have to undergo surgery that's potentially risky for them and can be very arduous for them to recover from. Now, I do think we're getting a lot better with how we're able to do these surgeries, right? Like with advances in techniques and whatnot, we're able to do these fairly extensive surgeries, I think, in a lot better way with a lot better results than we used to be. Even like 10 years ago, the way we've come is really pretty remarkable. So I do think that we're getting better at that, but it's hard because there's only so much they can exercise their way out of. When you're 70 years old, it's hard to build muscle. It's really hard to build muscle. I mean, when you're 60 years old, it becomes a lot harder to build muscle. So they kind of reach this point where they can no longer exercise their way out of it. That's kind of what I'm most interested in from a research perspective, because I think if we can figure out ways to like make patients stronger, like to boost them physiologically, then they may be able to undergo these surgeries in an easier way. So, you know, if you can make somebody's muscles like the same as like a 50-year-old, then they can undergo the surgery and have a better result from it. That's why like I really think it's very fascinating, the idea of prehabilitation, the idea of like how good can we make somebody before surgery.